Good morning, good afternoon, good evening, wherever you're calling in from. Happy Good Friday, happy Passover, happy Ramadan to everyone. Lots of events going on these days. I want to go ahead and introduce myself. I'm Jason Rosenfeld. I am the co-chair of the CUGH Global Health Operations Committee. I'm happy to be with you today to share the next couple of hours with you all here in this virtual environment. I'm privileged to be serving in the capacity of the Global Health Operations co-chair now for 2 years, and happy to see that my other co-chair, Richard Wilmot, has also joined us this morning. Richard, do you want to say a couple of quick words before we jump in?
Yeah, hello, good morning, Jason. Good morning, everyone here, colleagues from the committee and all the participants. I'm in Boston, and it's been a pleasure being part of this group and organizing group, and look forward to engaging with all of you with regard to the subject of our satellite panel. So good to be here, Jason. Over back to you.
Yeah, thank you, Richard. It's good to see you this morning. Good to see everyone again. And so I'm going to go ahead and re-share my screen. Give me 1 second. We have what I hope you will all find is a very exciting schedule for you today for this virtual satellite session entitled Challenges and Opportunities for an Equitable and Sustainable Future. But again, before we dive into the meat of our presentation or our session today, just a couple of quick housekeeping items. We do appreciate that everyone keeps themselves on mute throughout the presentations and the discussions. Whenever you are ready to share, please unmute yourself, join the conversation. If you're not feeling comfortable or you're in a place where you're not able to unmute, please feel free to use the chat function. Again, I'm going to slide back to these slides here so we can orient ourselves. So this is the button for unmuting ourselves. Here is how we start our video. If you would like to share the space with us more intimately, sorry, these are on an animation. And then if you want to use the chat function, it's going to be this button here. Or sorry, I'm looking at the wrong screen here. This button down here. And so if you're on your phone, it looks slightly different, but you'll still find the same tools down at the bottom of your phone. We will have a couple of—
Jason, excuse me, I'm sorry if I can interrupt for just a second. We're seeing the presenter view, so we can see your next slide up.
I don't know why it's doing that. Still?
Yeah.
It's so ridiculous. I'm like choosing the right screen here. What about that one?
Oh, perfect. Great.
All right. Thank you. It's always like the big concern of sharing in Zoom. It's like you can see behind the scenes. So thank you. Good to work it out now. We will have a couple of breaks built into the session today. Once we take those breaks, feel free to get up, take a stretch, have a bio break. We'll pull you all back. And then in the second part of our session, we'll use breakout rooms and we'll send you all into small group discussions. If you're not sure how to get into a breakout room, we'll make sure that you get into the breakout room of your choice. So let me go ahead and get started with this. But before I do, I would like to just allow Sri Mahankali to introduce himself. He'll be my co-moderator for today's session, also a member of our CUGH Global Health Operations Committee. Sri, would you like to unmute and introduce yourself?
Thank you, Jason. I'm glad to be here and glad to see so many people up early this morning and participating in what I think is a very important learning session for all of us. Privileged to be on this committee and to work with all of you, and also to see participants from all over the globe in this satellite session. Looking forward to it.
Yeah, thank you, Sri. And we're going to invite you to join a virtual live poll here in just a little bit, where we'll get to learn a little bit more about who you are, where you're coming from, and what your interest in the topics from the Global Health Operations Committee might be. But let's jump into this. So as a brief introduction to the Global Health Operations Committee, we are one of 8 standing committees within the CUGH consortium. And our focus is really on identifying and developing principles to enhance both university as well as organizational administrators' procedural and financial alignment. So really what we are is we're the nuts and bolts and administrative systems of global health practice. Helping practitioners, helping researchers, helping our service delivery arms of global health collaborations achieve their goals, right? So it's in education, research, service activities. Historically, we have focused a lot on how do we best manage international risk as we are sending our learners, our faculty, our staff around the world to engage in programming to address health equity around the globe. We spent a lot of time also thinking about how do we develop the legal frameworks to ensure equitable and inclusive global health programming. And then finally, thinking about these ideas of establishing and sustaining global health partnerships. So we attempt to bring together best practices and lessons learned from within our CUGH institutional membership, but also casting a wider net like this operations committee satellite session to those who may not be members to tell us what are they learning, what are they doing, and how can we best improve our engagement from global health practice. So that's our overall approach and focus within the Global Health Operations Committee. We do currently have 4 subcommittees working within our committee, and these are the administration and oversight best practices. And this group is working with the Institutional Exchange and Communication Subcommittee to focus on a survey on operational support mechanisms for global health. So they've been collecting feedback from key stakeholders and institutions around the world. And in fact, today we're going to get a sneak peek into some of the data that's been collected over the last year from this survey, which I'm really excited about. I've seen the data a little bit, but I haven't deep dove into it quite yet. We have a committee on the Global Health Travel Toolkit. This is one that our committee's been working on for a number of years now, and this is meant to be a ever-evolving dynamic tool that anybody in global health operations can draw from to again identify best practices in preparing our learners to go overseas wherever they're going. What are the safety and security briefings that we should be offering? What are the emergency response protocols that we should have behind our global health programs to ensure the safety and security and success of our global health endeavors? And then finally, we have the Voices of Global South subcommittee, which is focused on really trying to bring the perspectives and the experiences of partners in low and middle income countries around the world to the operations committee. And we have been working over the last couple of years on a white paper focused on LMIC partner perspectives of global health programs from high income countries. And I'll be sharing a little bit of our results of that white paper, which will soon be published on the CUGH website. So that's about us. That's who we are as a committee and the work that we've been undertaking. For today, these are our 4 primary objectives. So we want to think about defining an inclusive and equitable governance and operational frameworks across high income countries and low and middle income countries, collaborative partnerships. CUGH has a primary focus, as does our committee, on really thinking about how do we break down the barriers between LMIC collaboration and an input into CUGH activities. We want to look at challenges, opportunities, and possible solutions to global health operations around the world. We want to think about at least one unique issue at each participating member institution's operations that we can require immediate attention, really with the goal of thinking, what can this committee do for you moving forward from this satellite session? And then finally, we want to get some feedback on some of the products that we've been working on as a committee, again, to think about what should we be tackling next to help you do your jobs as well as possible. So this is our outline. We've broken it into 3 parts, roughly into equal parts. So part 1 will be focused on delivery, or overview of our products and deliverables over the past year. We'll be looking at that LMIC partnership white paper, the survey results, and we'll have a brief overview of our global health travel toolkit. Part 2 will be breakout room discussions, and I apologize, I did not get a chance to update this slide. But as a last minute addendum, we have combined the MOUs or contracts with the global health financing. So we'll have 4 breakout rooms instead of 5. We'll have a breakout room on LMIC to LMIC travel challenges, workforce development and shortages issues, and then technologies and global health. Those sessions will be moderated by our amazing committee members. We'll be taking notes on those sessions so that we can feed back to you what we've heard throughout the conversations. And then finally, we'll come back into the main room to debrief from those breakouts and then have a wrap up and any sort of networking that we would like to engage in. So that's our plan for today. Any contributions or anything that I missed from my committee members that we would like to cover before we jump into the meat of our session today? What I am going to ask, sorry, go ahead, Richard.
Oh, no, I was just going to say that the outline, it looks perfect. Hopefully we'll be able to maintain our time horizon so that we can go through all of these, all of this agenda that we have for today. But thank you for a wonderful introduction to the satellite event.
Great. Yeah, thank you, Richard. At this point, Matthew, would you mind putting the link to the Google form in the chat?
Of course, of course.
And so again, this is meant to be an unobtrusive, brief survey. We really appreciate you just taking 5 minutes while we're kind of getting ourselves into the next part of our session here. Tell us about yourself. Tell us about your interest in global health operations. Again, this helps us understand who's in the room with us today, but also what we should be prioritizing into the future. So thank you, Matthew, for putting that in there. We also invite everyone, now that you're here in the room with us, just in the chat, if you can just put in your name, the country that you're coming from, and the type or the institution that you represent or you work for, whether it's an academic institution, a non-governmental organization, a governmental entity, whatever it might be. But if you can just put it into the chat, let us know who you are. It'll help us just create more of a community today and a conversation as we move forward. So really appreciate that. And at this point, I believe I'm going to hand it over to Shri, who is going to lead us off into the part 1 of our session today.
Jason, can you advance the slides because I can't do it from here for some reason?
Yeah, you just let me know.
Okay, yeah. Thank you, Jason, for that great introduction. And thank you all for joining us this morning, committee members and all the participants. As Jason outlined in the introduction, this part of the program is basically going to be having 4 distinguished speakers from our committee. They're from various parts of this committee. We'll start off first with the co-chair of our committee and also my co-moderator, Jason. I'll not be spending too much time on introducing all of our speakers. They're all very distinguished, and I could spend the next couple of hours talking about them. You'll also find their bios on the CUGH website after the conference. And you'll find some information about contacting them and their institutional affiliations at the end of towards the end of this presentation. So we'll start off first by talking about the LMIC white paper, which was a paper in the works for a couple of years. What that does is describe the nature of interactions and collaborative partnerships between high-income countries and low-middle-income countries. It's a paper that our committee put a lot of work in. And our distinguished speaker this morning to talk about the LMIC white paper is my co-moderator and co-chair of this committee, Dr. Jason Reisenfield. Over to you, Jason.
Thank you, Shri. And I promise you won't have to listen to me throughout the entire morning. Yeah, so I want to just give a quick introduction to myself. So as I put in the chat, I'm Jason Rosenfeld. I'm an assistant professor in the Department of Medicine at the University of Texas Health Science Center in San Antonio. I'm the director of our Global Health Education Program and have been for the past 12 years. I cut my teeth in global public health as a U.S. Peace Corps volunteer in Ghana, West Africa, and I've been privileged to partner with researchers community-based organizations and governmental entities across West Africa, the Caribbean, and now in the United States. So I'm excited to be with you again today. For any of you that were here with us last year, this will look very similar, but I wanted to give a quick overview of the white paper and then just give you a teaser to say this will be published on the CUGH website here in the coming month. And then I wanted to open a conversation about what can we do next to expand the reach of this. So the background to this was the operations committee and with prior leadership was looking at the fact that there were growing global health programs around both high income countries as well as in institutions in low and middle income countries. And while we were looking at the attempts to build relationships and partnerships, there was this recognition that oftentimes those attempts are clumsy and one-sided, being driven by institutions from high-income countries where oftentimes the funding and unfortunately the power resides. And so in addition to that, many of the guidelines that have been developed, including even our Global Health Travel Toolkit, are focused on high-income institutions. And so really this white paper was an attempt, this survey, which resulted in the white paper, was an attempt to understand how can we in academic and other organizations in high-income countries best engage with partners in low and middle-income countries to create a more equitable version of our global health partnerships. And so what was done was the former co-chair of this committee drafted a really simple survey with the two questions you can see here on the slide. What do you wish partners in high-income countries would do better when reaching out to you to explore partnerships? And what do you wish they would do different in terms of how they approach you or develop relationships? Two real simple questions. We started off with networks within Africa. We sent the survey to 280 members of the African Medicals Association, as well as the AfriHealth Secretariat, and we got 26 responses. So best efforts, we sent the survey out twice, December of 2019 and again in February of 2020. And those were the results that we got. I recognize that our results are clearly biased towards the African continent, and even within that, to representatives from Nigerian institutions. And so regardless, we strove ahead and we developed our results, which I'll be sharing here in just a moment. We did a content analysis of the responses and looked at verbatim responses. And at the end of the day, with the support of my committee members, we developed this proposed framework for achieving equitable partnerships in global health operations. The themes that emerged from your responses were across this: building relationships and commitment. Before a partnership begins, the relationship must be built first. So don't go straight into business. Come and let's talk about who we are and what our interests are, and then let's find common ground, and then we can begin to build the partnership. So understanding is the first point of departure. We then have to look at how do we make shared decision-making and goal setting. So again, rather than the high-income partner coming and saying, this is what we're doing, listening to partners in low and middle-income countries and finding alignment in that space. Communication, transparency, reciprocity, and inclusivity was key. So there has to be an acknowledgement, implicit acknowledgement of power dynamics and where that power does and does not exist. There needs to be an understanding of reciprocity. It is not just the high-income countries sending their learners and faculty to low and middle income countries, but how do we create opportunities for cross-fertilization and cross-learning? There needs to be an understanding of equal authorship and then transparency and equal access to funding. And then finally, the fourth theme was around capacity building and continuous monitoring and evaluation. So we in high-income countries need to find better ways of increasing the flow of resources, both financial as well as human resources, to low and middle income countries, and always assess the quality and the impact of the relationships. It's not just the research outcomes, the programmatic outcomes that matter. It is the quality and the depth of the relationships that we're creating that also matters. So we have to be thinking about those pieces. And so across all of this, we need to be thinking about fairness, respect, trust, and empowerment. So it's been an interesting journey. There has been other writing in this space, primarily around global health research operations, but this was the first time in our literature review that we found this type of work focused broadly on global health operations. So educational activities, service delivery activities, as well as research opportunities. And so we, like I said, plan to publish this within the next month. But here's my question to our learning community, and this is where I'm hoping you all will engage with us. So we want to expand our sample size. We want to expand regional representation to include Asia, Latin America, the Caribbean. So here are the two questions. How can we best engage with you to collect this type of information? And what are the types of questions that you would like our committee to be asking you so that we can best build recommendations for sustainable and equitable global health partnerships? So I'm going to pause there. I would love to hear anybody's thoughts from our participants today. Please feel free to unmute for your responses in the chat. But we'll take about 4 minutes until about 8:30 to kind of see what discussion comes out of this. So how can we best engage with you? Is it email? Do we do Google Forms? Do we create a really intensive online survey? Do we have focus group discussions, webinars? What would you like to see from this operations committee? How can we engage with you? Please don't everyone speak at once. Yes, Hannah.
Hi, I'm Hannah Rutledge. I'm director of the medical library at University of Pennsylvania Libraries. And this is my first time kind of dipping my toes into this CUGH, and I was encouraged to do so by my colleagues at the Center for Global Health. We work closely with some librarians in Botswana, and we're establishing relationships with others. The libraries are in partnership with our Center for Global Health. And I'm here today with my librarian hat on because global health is of particular interest to me personally. And my conversations with librarians across different areas of the Global South, as well as some of my fellow library directors here in the US, we see the inequities around access to information and published information related to health and clinical. And I'm curious as to how I or other librarians can engage in this work that y'all are doing to help advocate for that and to help utilize our connections with vendors and publishers and open access and open science to really push for it, particularly in this work and this effort. And so that doesn't really answer the question that you posed, but I guess my general response is I want to be engaged and I want to contribute. If you all see that as beneficial to this work, and I would love to brainstorm in any way, whether email, Google Forms, I'm on all of those platforms. So I'm open to whatever the rest of the crew decides.
Well, Hannah, I want to thank you for joining us today. And I think you're working in a space that many of us, I know, oftentimes don't think about in terms of the library sciences and the access to information. So my response is we would love to have you or a representative from within your network join our operations committee to help us think about that piece of it, right? Because we oftentimes think about research primarily, and then there's a program, there's an educational piece, which is also really heavy, and then sometimes the programs. But I can tell you, at least within our committee, we haven't spent a lot of time thinking about information dynamics and information resources. So I really appreciate your sharing that, Hannah. Aaliyah, I see your hand is up.
Yes, thank you, Jason. I'm sorry I'll not open my camera for better connectivity. Elia from the Democratic Republic of Congo, Executive Director for the Council on Health and the Academy of Medicine, COSAMED. And I can be also interested to be engaged on this. But the great mistake that we have in global health is not to listen for local voice. It means we must see how to increase the local voice for global health solutions. It means to engage this group to build a framework with even a Google group and a frequency even meeting. We can build also how we can build a newsletter which can raise the local voice to see how we can orient global health solutions. That's what I'd like to add. Thank you, and over to you.
I'm muted. Thank you so much, Leah. I appreciate you sharing that. And that is definitely one of the goals of our committee, is bring that local voice in. Sri.
Thank you, Hannah, for bringing up that great point. In an earlier life and in a different domain, I had worked with an entity called the African Library Project, which is based in California, which has deep roots in sub-Saharan Africa. Of course, they have not done anything from a global health standpoint, but they, in conjunction with you, would be, in my opinion, a great partnership, because they have nailed down all the logistics in terms of mailing the books from here and all of that. They use media mail, so they get it really cheap, and they have everything from the shipping to the transport and to the distribution nailed down. So potentially what they have is a form on their website that allows partners on the other side of the equation to detail what it is that they'd like to receive. So it's kind of a needs assessment and a readiness assessment. And then once they get that information, they collect books from schools here, libraries here, those kinds of things, and then shipped it out. So they really have a very well-oiled operation, and I can see value in bringing you and the African Library Project on board to carry out some of this work that you're suggesting we do. So it's a great thought, I think, and it's also a very timely and relevant thought. So thank you for sharing that.
Agreed. Abara, and then I'm going to move us on, but please, Abara.
Yeah, just Hannah, thank you very much for the library component of what you said. I personally feel that we should engage multidisciplinary teams using all the technological communication tools that's available currently. And if we can afford it, create some focus groups, engaging multidisciplinary global health professionals and exchanging information. I think that's going to really bring the whole world together, not just South or North, but South and North, and East and West. Thank you.
Thank you, Abara, and thank you all for this great conversation. I'm gonna end it here so we can move into the next part of our presentation. But thank you, Hannah, and thank you, everyone else. Sri, I hand it back over to you.
Thanks, Jason. Wonderful presentation and very valuable in the context of where the world is at this point. So our next set of distinguished speakers for committee members here, Alison Lofthouse and Anna Helova, what they're going to be doing is build on what Jason just mentioned and dive into the numbers and kind of give you an overview of what our 26 survey responses indicated to us in terms of our future steps. As Jason mentioned, we mailed out the survey to about 280 members, if I have the number right, and we had 26 responses. And as Jason also mentioned, these were fundamentally Nigeria-centric in some ways, but it was also a valuable lesson for us in terms of what to do next. So I welcome Alison and Anna to take this process forward by sharing and doing a deep dive on the survey that they conducted and put a lot of effort into. First, if you could please introduce yourselves in 30 seconds and let participants know who you are, what your affiliations are, and what you do. Thank you for joining us this morning.
Great, thanks, Sri. Hi, everybody. Thank you very much for joining the Global Health Operations Committee satellite session today. We're really happy to have you here. My name is Allison Lofthouse. I'm the Assistant Dean for Global Health at the School of Public Health at University of Illinois, Chicago. Anna?
Hello, everybody. I would also like to welcome you to this satellite session. I'm an assistant professor in the Health Policy and Organization and a deputy director and the director of Global Health Studies at the Sparkman Center for Global Health at the University of Alabama at Birmingham in the US. And I would also like to, Carrie, if you can introduce yourself as well.
Thank you. I am Carrie Brossard-Stoos. I'm an associate professor and associate department chair in the newly formed Department of Health Sciences and Public Health at Ithaca College.
Great, thanks so much. So we're going to talk to you a little bit about a survey that we conducted. We really sought out to understand the nature of the organizational structure, administrative processes, and funding strategies of global health units. We have about 20 minutes here, so we're not going to go over everything, but we're just going to give you a highlight of some of the data. So, as I mentioned, we're a part of the Global Health Operations Committee. We are two subcommittees that join forces to conduct this survey. I just kind of described the goal of the survey, and we use Qualtrics as our platform. We developed the survey in the fall of 2021, and this was, we developed it over multiple committee meetings and discussions and pilot tested it in 2022 and deployed the survey. We use Qualtrics as our platform. We sent the survey out via various methods. We sent it out via newsletter, direct solicitation. We all individually reached out to our partners, particularly those in LMICs. A big thanks to the president of AfriHealth, who was so kind to send it out to the Global Health Network, the AfriHealth Network, I should say. So we really tried to obtain a representative sample. The survey is geared towards those in leadership roles. We conducted descriptive analysis for the numeric responses and then content analysis for the open-ended questions. Next slide, please.
So we ended up with 44 respondents. And as you can see here in the first category here, the primary geographic location, we had about 32% from North American region, 30.8%, sorry, from the North American region. We had about 18% from sub-Saharan Africa, and then we had individual respondents from the remaining sections. So one respondent from Middle East and North Africa, one respondent from Europe and Central Asia, and one from South Asia. We also had one respondent that did not indicate their location. The types of institutions varied, with the majority coming from academic institutions, about 75%, but also respondents identifying with clinical institutions, NGOs, and then other institutions such as library and research. And then finally, the primary focus areas, we had a large group from education, focusing on education and training, which makes sense due to a good percentage coming from academic regions, but we also had primary foci in research, practice, and community engagement, clinical care, and other respondents.
Next slide, please. So in terms of the governance structures, we asked where global health sits within their unit, and we received a variety of responses. As you'll see here, that the majority of global health sits within the medical school, but also across other health science colleges. So those being pharmacy, public health, nursing. And then some of the respondents did indicate that it sits more at the central level, at the level of president, provost, or vice chancellor, and then other. And so some of the responses that we received for other are types like the Center for Multicultural and Global Health, or an entity that it sits within a college, but it's a standalone unit, self-funded, et cetera. And then the follow-up question was, how is your global health department governed? And so you'll see here that we have the respondents identified different governance structures, such as department heads, internal and external advisory boards, board of directors. And there was an emphasis on the internal advisory boards or groups. I would say that a surprising and somewhat delightful finding was that the student group governance was more than the board of directors and external advisory board. So that was a little bit of a surprise. And then people identified other structures and other governance structures. And so in terms of those responses, just to give some examples, people said that they're completely decentralized. It's just up to the individual units. And then other people had responded saying that it's governed by a group of core faculty members. Next slide, please. And we were curious about the various types of services that are offered, and at what level they're offered. So obviously, you know, to conduct global health operations, there's a variety of services: financial services, human resources, legal and contracting, etc. So here we're showing you the various levels at which the majority of the provision of services sits. And so in terms of, you know, banking and procurement and the MOUs and contracting, these ones, the top three, you'll note that they primarily sit at the central administration level. And then when you start getting into travel and risk management, communications and fundraising, that there's a little more, those kind of run across units, if you will. Next slide, please. We were also curious about the financing of global health units. And so we did ask, where does your funding primarily come from? And you'll see that we found that there's a lot of institutional support. Nearly 30% are funded by the institution itself, and then approximately 35% are gift funds. And when we break that down further, it's pretty much a even split between restricted gift funds and unrestricted gift funds. And then there's some other sources in terms of tuition revenue, clinical income, dues, etc. The one common theme is that nobody has enough money. I don't think that's any surprise to any of us. But of course, you know, that was mentioned in the open-ended responses. Next slide, please. Anna?
Yeah, thank you. So just very quickly, when we asked about the greatest risk and the greatest operational challenges in global health, we received the responses that we grouped under 5 categories. Just a reminder that most of these surveys were completed during 2022 when we were amid COVID-19 pandemic. And so that might have affected these responses and changes in the institutions. Nevertheless, some of these topics are, I think, timeless and were very relevant before, during, and after the epidemic. So some of these areas were global safety and security, then global health not being a strategic or institutional priority. So for those of us working in global health, we know that's always an issue to sell in the US institutions. Why should we prioritize international operations versus the local operations? Then again, COVID-19, as well as any other societal disruptions, whether it is due to the conflict in the country or climate change events, all this kind of stuff. Lack of operational support for global health activities, lots of bureaucracy and restrictions at institutional level, as well as lack of sustained funding, as Alison very nicely elaborated on. Okay, next slide, please. Going back to Hannah's comment and what we discussed just a second ago, we also wanted to know a little bit more about what we can do to share our resources and knowledge across the globe, and what would be the good platform to do so that would be accessible and would address any kind of inequities in knowledge and sharing of the resources. So some of the needs that our respondents identified was a need for searchable database, for networking and collaborations and developing those partnerships, templates and shareable resources. So a searchable database, resources for international human resources and contracting, procurement. So human resources was one of the issues that has been repeatedly mentioned. So within the survey, as well as forum for discussion of international safety and issues. Next slide, please. So we wanted to share with you that another CUGH committee developed this nice capacity strengthening platform. It's focused on most of the skilled health workers and the shortage globally. But I think it's a very nice resource that people can already use. And I think it's an exciting basis for us to build upon to provide all these other resources in other global health operations and other areas. Next slide, please. Okay, so when we ask about the platform that is currently that is preferred by the institution for the shareable resources, most respondents said that they are using Microsoft Teams, Google Drive, Canvas, and then Slack and some other resources. When we look more deeply into the comments, most of our responders, as a reminder, were from the North American region or the global North in general. And so the Microsoft Teams was the one that was preferred by the global North. However, global South, many of the LMICs prefer Google Drive or other Google-based platforms. Next slide, please. And the same is really reflected on this slide, what platforms are currently being used by the institution. So again, a lot of respondents mentioned Zoom, Microsoft Teams, across the board, whether you were in LMIC or high-income country, a lot of respondents mentioned email as a primary source of sharing information, WhatsApp, Skype, and then Google Meet, or one respondent mentioned good old phone. Next response. Next slide. I'm sorry.
And so just to review, thanks, Anna. And so just to review some of the takeaways from our survey, we need a clear definition of global health operations. It came across very clear that we don't have a clear definition. Operations are occurring across all administrative levels. Funding's mainly coming from the institution itself. Of course, you know, the issue of units being underfunded, and that there is a need for communication, shareable resources, and various platforms. And so thanks for Anna for kind of giving that overview of the platforms that are currently being used and some of the requests that we received. Also, she highlighted some of the existing resources, that it's really important to get the word out about these existing resources. So the travel toolkit, which our colleague Chris is going to talk to you about here after this presentation, and the capacity building platform that is spearheaded by Dr. Andrew Dykins, a colleague of ours that is in CUGH, as well as a white paper that Jason already spoke to you about this morning for developing sustainable partnerships. But we are curious, and we'd love to hear from you about what would be helpful to you in carrying out your global health work, because that's what we're here to do, to try to create products that would be of use and value so that you can do your work better. And so some of the needs that were expressed were searchable global health specific database for funding, various workshops, seminars on global health operations management. So the issues of HR, again, partnerships and networking, communication, MOUs, contracting. And then Anna and I were discussing this, just, what are some possible products that we could create in order to fill these gaps? And so, of course, we've thought of toolkits or webinars or checklists. Do we need another database, a white paper? But again, this is why we're having this session, to hear from you about what you think could be of value to you in your work. And so we'd just love for you to either put it in the chat or even just unmute yourself. Next slide, please. So some of the limitations that we've mentioned several times, you know, it was primarily overrepresented by US academic institutions. And then again, that the survey was deployed during the pandemic, and it's possible that's, you know, that there was a hold or halt to certain service provisions. So when the respondents were saying, well, they don't do that, you know, but it's basically, you know, it was just a function of them being halted because of the pandemic. Next slide, please. So in terms of acknowledgements, obviously our survey respondents were very grateful because we wouldn't be able to do what we're doing without having people take the time out of their day to respond to the survey. Keith Partica is a team member of mine, and he helped build out the survey in Qualtrics, so I'm grateful for him. Carrie, who presented on one of the slides today, she took the initial stab at the data analysis. So Carrie, thank you for doing that for us. And of course, the CUGH Operations Committee for all their input and insight, and CUGH leadership for disseminating the survey throughout their networks. Same to AfriHealth. We're just really grateful to the president and CEO, Dr. Kiguli Malwadi, the president, who was kind enough to send it out. So thank you. And then next slide, please. And so in terms of having just a bit of discussion here, again, what are your greatest global health operational challenges? What are some resources that you would like to see come from us? And any other questions or comments that you'd like to put forth? Thank you.
Yeah, thank you so much. And to start us with the discussion, there are just so many aspects of these operational challenges that we encounter in our global health operations all the time, but they are underrepresented in our discussions. And today, when Hannah spoke up about those manuscripts and access to libraries, that's a great example of that. I have so many colleagues from LMICs sending me requests. Can you give us the access to this publication? Can you share this with us? The same through the ResearchGate or other resources. And how can we expect people to prepare the research, to publish the manuscripts, to work in global health if they don't have equal access to resources? And so that's where we would like to help with these shareable databases, for example, or toolkits. Yeah, so please, we welcome your other comments.
Richard, go ahead.
Yeah, thanks, Alison, Anna, so much. I was just thinking in context of the comment that Hannah was giving with regard to library resources, access to those resources for collaborators, particularly collaborators in LMICs, and the cost connected to accessing databases and journals and all of that is probably an area, certainly as we have said already here, that we haven't explored, and would be interesting and useful to perhaps consider as a potential area of resource development for our collaborators. Yeah, thank you.
I can speak just what to our case. What we do for our collaborators is we have the ability to get them a university ID number that gives them ability to access our library systems and learning platforms. So Blackboard, and anything we have, like, for example, Qualtrics. In order for Anna to access our Qualtrics platform, I had to get her an external affiliate status. So it's called an affiliate, and we're able to do that. We do that with our international collaborators, because then they have access to the library system, and that has been I think that's the thing they like most about our partnership, is giving them access to information. So I'm wondering, perhaps it's a possibility at your respective institutions that might be one way, at least one small way, but actually big because it's so impactful, of getting information out there.
If I may interject on that, Allison, I realize a lot of institutions do that. We've been asked by our Center for Global Health here to provide that, and that oftentimes violates our licenses of those resources. And so not all institutions are able to do that. even here at Penn, we cannot provide access to library resources to some of our affiliates in our hospitals. I had the same thing at Emory. I was previously at Emory University down in Atlanta. And so it's a major issue. And not all institutions are legally able to do that. I know others just kind of turn the other way. Their libraries do that, but vendors and publishers are recognizing that. And so we could legally be sued.
Hannah, thanks for bringing that up, because there is a restriction on certain things that can be accessed. So I don't know the ins. I leave that to the librarians to determine. But thanks for bringing that issue up, because obviously that's really important.
Yeah, and the other side of that is that if you want to publish as an open access, right, it's costing more and more money, and there are no resources for that usually. So it is a huge problem. So,
Sri, you had a comment?
Yeah, I just wanted to add that one of the things that needs to be kept in mind in terms of providing access is that there's a digital divide. Not everybody has internet access, and nor does everybody have broadband internet for that matter. So one of the things that I learned from my experience on that African library project that I mentioned earlier is that they prefer to have books the old-fashioned way, because once the books or the literature was with them, and they were done with those books or that literature, they could pass it along to other contemporaries in their local locale. Granted that all of this literature and books may not be state-of-the-art and up-to-date like you'd probably see in the digital world, but it was something that provided them some basic understanding of what was happening in these domains. And then, for example, several schools didn't even have like 10 books. And so once they got those books and the students in those schools were done with those books, they had the ability to pass it along to other schools in their vicinity, which was much more useful way of propagating this information, even if this information was not necessarily state of the art. So I just want us to understand that there's some technological limitations in terms of providing digital access, in addition to some of the IP and legal issues that you all mentioned.
I would like to mention one of the activity that we had at University of Alabama at Birmingham. The Sparkman Center spearheaded the Spark Ed initiative, which was this device that created LS hotspot, so access to internet for about 80 people at the same time, while also serving as a big drive, basically, so saving electronic books and resources. So the kids in the school were able to connect to the internet while also accessing the books and resources, which is something maybe that can be extended to other institutions.
For the sake of time, I know Abara, we need to get Abara's question or comment in. So Abara, please go ahead.
Yes, Alison, thank you very much. My comment is just one. From your survey, predominantly, it was mainly from the US. And if you remember, I made attempts to distribute these to my network, and some of them had absolutely no idea of CUGH. And, I believe that the CUGH has a lot of work to do. It may be out of context, but some of them did not even know about CUGH. Some of them came back to me and said, well, you know what? We don't have global health, but I say you're practicing global health. So I think in addition to the survey, the CUGH, we have to make sure that we make people aware who we are, what we're doing, and engage all of us in this mission. Just a comment.
That's an excellent comment
work.
and a great way to close this session, Abara. So thank you very much for bringing that forward. Absolutely. All right, I think that we are able, for those that want to contact Anna or I further, here is our contact information. We'd be happy to speak to you about the survey in greater detail. So please reach out.
Well, Alison and Anna, thank you so much for sharing your wisdom and doing a deep dive on those numbers. We're all fortunate in the sense that it was that survey and the aftermath of that survey was a great learning experience. But we're now going to move on to another distinguished member of our committee, Chris Rappelje. Chris is someone who spent a lot of time on the Global Health Travel Toolkit. And this morning, she's going to briefly share her wisdom and insights of the number of years of work she's put into this travel kit. So welcome, Chris. Glad to have you here. And please introduce yourself and feel free to share your wisdom and guidance. Thank you so much for being with us this morning.
Thank you. I'm Chris Rappelje. I'm Director of Programs and Services in Emory University's Office of Global Strategy and Initiatives. And we are, our office assists faculty and staff across the university with global work. And I've been involved in the committee for several years. Just for some background on the toolkit, kind of pre-pandemic, when we were thinking about the various areas in which people can need assistance in running global health projects, one area that came up repeatedly was international travel. And many of you are probably familiar with a number of resources that are available out there from entities such as the CDC, or security companies, that sort of thing, on pre-travel protocols, preparations that should be made ahead of group travel, individual travel. We'll also have some specific guidelines and considerations for people who are working with in the global health context. For example, particular medical preventions that might be taken in advance, the kind of stuff that you might want to bring with you on trips, etc. So we knew there was a lot of information out there from third parties, and the goal was to kind of create a central place where we might provide all those so people could kind of not only get a big overview of the kind of issues that they might be should be thinking of ahead of travel, but then also be directed to those resources so that rather than have to kind of do a lot of Google searches and piece together information, this toolkit would do that for them. So one limitation that we have with the toolkit is that, I'm based in the US. My familiarity is with helping people who are in the US go out into the field to do global health work. And that very clearly limits its perspective. So we mainly reference sources such as the CDC, and the context of the toolkit is really apparent that it's to help people and this wasn't the intention, but it's what the material we have has produced. It kind of comes off as a resource to help people in the US or in the West go outside to go in on global health travel experiences. So what we very much like to do is expand this resource so that it's more relevant for people who are outside of the US, perhaps LMIC to LMIC travel, or perhaps people coming to the West, but just the kind of, we would like, in order for it to be more helpful, we'd like it to be more helpful for people outside of the Western context. So knowing what it could or should include to do that, what kind of resources people might be aware of that we could reference in the toolkit to serve people outside of the West. And really any ways that I imagine kind of the questions that occur to me as a traveler aren't even the same questions maybe that someone outside of my context might encounter when they go to travel. So I think you can advance the slide. Yeah, this is just an idea of the current structure with some topics that have been suggested for adding. And, you know, again, you'll see there's a point, for example, of registering with the U.S. Embassy when you're outside of the U.S., obviously only relevant for someone who's a U.S. citizen. So is there a parallel to, you know, ways that people from other countries should be or can be assisted with connecting with whatever public resources, government resources might be available in the country that they're visiting, and how to engage those resources. So, you know, I think anybody who's probably worked with group international travel or international travel for work and specifically for global health projects, this sort of design of pre-deployment considerations during deployment, post-deployment, will seem is pretty standard to how these sort of resources are designed. And so, you know, we're looking to expand and modify it again so that it can more, some of these topics would probably stay the same, but there might be additional topics we should add, and certainly additional content we should add to be more relevant to people outside of the US. So I think maybe the next slide. Okay.
I think that's the last one.
Okay, I didn't know if there was a, so anyway, for discussion, I really welcome any discussion here on ideas, but what might be more useful or kind of in line with how ideas occur to people is if people are aware of resources that could be added to this sort of, you know, when you think about all the resources the CDC has for global travel, are there similar global resources that could be made available that speak more to a non-US traveler? Also, anybody in the audience who has ideas of, now that we are embarking more regularly on travel, the kind of issues you've encountered, maybe you're currently encountering, that could be researched and reflected in this toolkit. So very much open for suggestions. We've posted this on the CUGH website, and the idea is to keep it updated. It got a big, you know, no one was traveling for 2 years, so that was reflected, and you know, we were worried about other things for 2 years, but now with people out and about, would really like to revive and continue to update it. And again, our specific lens is really wanting to make it more relevant to people outside the US.
Thank you, Chris. Can I make a comment?
Please.
I congratulate your team and the initiative, and to make it more comprehensive, we should look at global travel kit all around.
Mm-hmm.
South, north, east, west, and make it quite inclusive. Just like you rightly said, you as a traveler, you may have your own needs. Another traveler from another part of the world have their own needs and expectations. So I think this is a very good beginning now that COVID is probably over and we're going to be traveling a lot more. And this is a good time to launch it. And I'd like to congratulate you and your team for the work you do and are going to be doing going forward. Thank you very much.
Thank you. Sri?
Yes, Chris, just to build on what Ibarra just said, one way to look at it is like a core curriculum travel kit, and potentially with 2 subdivisions, one from those in the US going overseas and one from those overseas coming to the US. Because the requirements, as someone who's done both, the requirements for both those travels pre and within the pandemic and post-pandemic are hugely different. So we need to factor in that when we build further on the travel kit. So that's what I just wanted to add.
And do you think specifically to the US is its own sort of category, if you will?
Yeah, I would think so.
Okay.
Yeah, absolutely.
Yeah.
Richard,
Yeah, well, just one thing, Chris, to commend you, because I know as Jason in introducing the panel mentioned that this has been a document that we've been working on for quite a while. And I think it's already probably 4 or 5 years or so. So it's a tremendous, I
that's
think.
COVID years, so it
Yeah,
gets
yeah. So pre-COVID and then pre-COVID and COVID years. So really commendable that you've maintained at least a focused attention to this effort over those years. And I had posted a question just to emphasize what you're asking the audience here about other type of topics or experiences that they may have seen in their collaborations with colleagues. Yeah, but I think as a committee, I think just exactly what you have said, that this document is available on the website. I think we might just put the website here, actually, the URL. Is it there?
Yeah.
Okay.
We did that. It's in there.
Okay, great, yeah. So it is there, and it can be open to comment and future use for others as a resource, in fact, for all of our collaborations. Thank you.
So Chris, thank you so
Yes.
much for
Thank you.
sharing all your expertise in this particular domain. There's no one who knows this better than you. But we're going to transition now to our next topic, which is, Matthew, do you have the results of the poll that you can share?
Yes, I do. Thank you. And for the interest of time, I'll try to keep this short. I don't know if I can share my screen so people can see what I'm saying. But we got a lot of wonderful responses from all around for the question, what do you find to be the greatest challenge in global health operations today? Our top response, getting about 56%, was access to healthcare. Our top 4 responses were then after that, or top 3, health system strengthening was second, and mental health was third at 22%, and lack of clarity for global health, which I think all of these just referred to what we've been talking about. And then we had a lot of other responses across the board. As you can see, I think you can, are you seeing this? No?
Not really, Matthew.
Okay. Okay.
Julia,
so
is there
then,
some way Matthew can bring this up?
I am not able to share my screen. So I can just describe it. I'm sorry. The other responses that got that are I'm okay. I think we can share now. Here we go. Okay.
Perfect. Awesome.
So as I was speaking before, the first question, what do you find the greatest challenge? You can see the top response here is access to healthcare. The second highest response is health system strengthening with 39%. The third is mental health at 22%, and lack of clarity of global health operations in general is a 17% response. And then there are everything also got at least one response. So infectious diseases, antimicrobial resistance, non-communicable diseases, environmental health, and wealth distribution inequalities all got 2 responses. For our second question, what is a unique issue in your participating institution's global health operation that requires immediate attention? Overwhelmingly, people responded with mental health with 37.5%. Also important, highly responded answers were non-communicable diseases at 19%, climate change, and administrative processes also at 19%. And then we had COVID-19 pandemic, antimicrobial resistance, maternal and child health and funding requirements all had approximately 13%, as well as facilities improvement. Safety and security had no responses, but obviously that's still important. What do you consider the greatest opportunity to improve global health operations? Overwhelmingly, people responded with addressing health inequalities at 67%. Other highly responded answers were investment in health systems, advancing research and development, and strengthening international partnerships. Also, to note, promoting health education got 17%, and investing in global health security is 11%. And then finally, what is the most essential way that HICs can help LMICs succeed in global health operations? The top responses were supporting research and development, fostering partnerships, both got 41% approximately, sharing knowledge and expertise got 35%, and providing financial assistance got 29%. Also of note, addressing global health challenges got 18%, and offering technical assistance got 12%. So a lot of good, overwhelming responses. Thank you for allowing me to share this, and thank you. Hopefully this creates adds to the wonderful discussions that we've already had. Thank you.
Thank you, Matthew. And I think this really gives us some good reinforcement of what we're trying to do here in the Global Health Operations Committee, hearing a focus on fostering partnerships, addressing health inequalities, resource sharing. So I'm invigorated just on the first part of this conversation, because it's really, again, reinforcing what we as a committee have come here to try to do in our work. And I'm excited for the second part of our session, where we're going to have you guys all jump into breakout rooms to share with us really your thoughts and perspectives. So I hope everyone's warmed up. I hope you've gotten your coffee if it's the morning. I'm hoping you got your lunch if it's the afternoon, and maybe you're working your way towards dinner if it's sometime in the evening for you. But what we're going to do is we're going to take a quick break. So everyone gets a chance to refill their beverages, get a bio break, stretch your legs. So I'm thinking that we will come back at, it'll be 22 after the hour, whichever hour it is that you're looking at in your time zone. And so for me, it would be 9:22 a.m. So something 22 wherever you are in the world. We'll come back and we'll pick up on our breakout discussion. So thank you to all of our committee members for their presentations. Everyone take a short break, and I'll see you back here soon. Okay, everybody, hopefully you haven't gone too far away. Hopefully folks that stepped out of the room will rejoin us, but in the interest of time, I want to bring us all back and move us into part 2 of our session today. So thank you again to all of our committee members for their presentations this morning. I hope for our participants who have joined us from around the world that you are starting to get some insights and understanding into who the Global Health Operations Committee is, the type of work that we have been engaging in these past year, couple of years for that matter, and what we may be able to tackle here into the future. And we're hoping, you know, as we've been discussing so far, that you may find interest in joining this committee into the future, and or just contributing to the work that we're trying to do, maybe as an unofficial member of the committee, but helping us think through these issues and these challenges of creating more equitable global health programs. And so to that end, part 2 of this session is going to really be focused on some small group discussions. So again, I hope everyone's been warming up their vocal cords and shaking off any concerns they may have about sharing, because we're going to break into some small groups where we'd like to hear from you. And so what I'm going to do is, in a moment, I'm going to show you the 4 breakout rooms that we have made available, but we want you to choose the topic that you're most interested in. We're going to have about 45 minutes in these breakout rooms to discuss amongst ourselves. So our committee members have pulled together some discussion prompts around these topics. And really, this is an opportunity for you to share with us what's on your mind. What are some best practices that we can bring forward? And then once we've completed those discussions, we will come back into the main room to have a broader discussion where each of the rooms will report out what they've discussed, key lessons learned. And then we'll start to bring this satellite session to a close. So these are the 4 breakout rooms that we have organized for today. We developed these breakout rooms in response to some feedback we've already received from our learning community, as well as from other priorities we've heard in past discussions. And so the first breakout room, room number 1, is going to be focused on international contracts and financing. And this room is going to be moderated by Anna Halova. So thank you, Anna, for taking leadership on that session. Breakout room number 2 is going to be focused on LMIC to LMIC travel challenges, right? And this came from CUGH leadership expressing that they had heard from many of their member institutions and others that it's not just a challenge for partners in low and middle income countries to come to the US or Europe, but there are additional challenges that don't get talked about between inter-regional travel. And so we really want to focus on that in this discussion. That discussion is going to be led by Dr. Emanuela Ibarra. So perfect timing coming back, Dr. Ibarra. Session breakout room number 3 is going to be focused on workforce development issues and shortages. This will be led by Shri. And then number 4, technologies and global health operations. This will be led by Annalicia Pickering. So each room will have a session moderator as well as at least 1 note taker, and they will be documenting the conversation, sharing their screen so everyone can follow along with what we've been talking about. Before I move us on and talk about how we can break into these breakout rooms, I want to see what questions anybody might have, any comments from my co-committee members about the breakout sessions and what we should be expecting. Okay, so again, contracts and financing, number 1. LMIC to LMIC travel challenges, room 2, workforce development and shortages in room 3, technologies and global health operations in room 4. I think at this point, if there are no other comments, Julia from CUGH administration is going to open up those rooms. and you should see a prompt. I'm going to stop sharing so that this becomes a little bit easier for people to see. And then if you have trouble going into a room, please let me know, let Julia know, and we can help put you into that room so you don't even have to stress about it.
Jason,
right.
could you remind us how long the breakout rooms last?
So we're going to give ourselves at a minimum 45 minutes, and I would just say you can stay in touch with me. If you need less time, then we can come back earlier, but at a minimum 45 minutes. So we will plan to be in the breakout rooms until about 5 or 10 minutes past the next hour.
Thank you.
And as a reminder, did you want moderators to record the breakout rooms, or what was the decision there?
In terms of when we come back?
In the breakout rooms themselves, were we planning separate recordings or not?
Oh, I would say if you can do the recording, go for it.
Okay.
That way we just have the backup.
Okay.
And Don is asking, can you switch between rooms? Of course, we're not going to keep you in one room. If you want to jump out, I will stay in this main room if there's any issues. So Don, if you're still here, hopefully you heard that, you can jump back and forth. Does anybody need help getting into a breakout room? For those of you still in this main room with us, again, we'd love for you to go join one of these small group discussions. If you need me to pull up the slides that show each of the different rooms, I can do that again. If you need help getting placed, let me know. Anna, everything okay?
I was going to ask, I cannot share the screen or record. It's not enabled as a host. Would you be able to do that for me?
Yeah, Julia, could you make Anna host real quick?
In room 1.
Yeah, you should be able to do that now.
Thank you. Does anybody here in the main room need help getting into a breakout room? Willa, Eric, Martin, Mona, Reddit, would you like some help getting into a breakout room? Do you need anything from me? Eastman, which room would you like to go into? I can go ahead and help you get into that room. If you want to put it in. Yeah.
Thanks, Jason. Would you kindly quickly go over the rooms again?
Yeah, so we've got a room on contracts and financing. We've got a room on LMIC to kind of LMIC travel challenges and opportunities. We have a room on workforce development and shortages, and then a room on technologies and global health operations.
I'll take the technology group.
All right, I will send you there now.
Thank you, sir.
Mm-hmm. Willa, Martin, Eric, can I help you get into a room?
Hi, in my breakout room, they wanted to share their screen, but they need participant sharing to be enabled. I didn't know if anyone would be able to enable that.
Which breakout room is it?
Technology solutions. Technologies.
okay. I'll go in there and make sure they can share.
Okay, thank you.
Hey, Keith, how are you?
Jason, how are you?
Good, good. You
Good
want
to
me to
see
throw
you.
you into a breakout room for the last 5 minutes?
Well, I was actually in the blindness one. So we've been working with ophthalmologists around the world to deal with the issue of blindness, which, as you know, is it's a really low-hanging fruit. I mean, it's just huge numbers of people with vision loss and simple, cheap ways of screening and resolving that. So
Right.
they, so working with them for a few years on this. So they had a session, and then we had the students one, and then yours. So I apologize for being a little bit late, but how are
No
you?
worries. I'm doing
How are
well.
you?
Yeah.
Sorry?
Okay. No, we're doing well. It's been a good discussion so far.
Yeah, I apologize for being late, but we're trying to toggle between multiple ones at the same time. But I wanted to thank you very much, Jason, and for all your leadership with Richard. But I know Dawes mentioned to me, I owe you an email that she mentioned that you'll be leaving the chairship, and I just wanted to personally thank you. You've been an outstanding leader of this committee with Richard, and I know you poured an immense amount of work, and I'm just really grateful to you. Congratulations on your grants, importantly.
Yeah,
but we hope that you'll be able to continue with us, and we don't let you go. So, but in a different capacity.
Yeah, that's my intention. And again, I appreciate the opportunity to lead the group. It's definitely been a learning experience, and I've enjoyed, in particular, just building the relationships. So although I don't do as much focus these days on global health just because of the pandemic, I'm still involved. I still direct our global health program, and I'm fortunate that I got these big grants. So
fortunately, yes, right. Congratulations. This has been wonderful.
Yeah, thank you.
Yeah, but let us know. I mean, as you will go into that, you'll have a lot of work, but we really like you to loop back at some time and continue to work with you. You just are just really fantastic. So
thanks, Keith.
And
yeah, so we got about another 5 or 10 minutes in the breakout rooms. So, and then we'll come back and have a group discussion.
Okay. And if there's anything we can do with your work at the university, let us know. And share with us what you're doing, what the university's doing, and vice versa. And obviously that river, that pipeline of knowledge and engagement will continue. So
yeah, of course.
The grants you had, what were they in?
Sorry?
What were your grants in?
So I've got 2 as a sub award to the city of San Antonio. One you focused on addressing health equity through health literacy principles. So we've been leading a citywide program to do a bunch of different things: community-based health promotion, training health professionals, empowering local organizations, providing like plain language materials around COVID. And so that's been fun. It's been kind of a pivot to some new things. And then I've got a CDC grant sub-award that's focused primarily on health promotion using a model of peer-to-peer education that I've been working with for about 20 years now, called Community Health Clubs. And then the third, which came in last year, was a HRSA grant to design a community health worker training program. So I've been working with partners here to create a collaborative that will be increasing the CHW pipeline and workforce over the next 3 years. So,
do you have curricula in that regard, Jason? Because we've been, obviously, as you know, speaking with our AfroHealth colleagues on strengthening the community health workforce to strengthen public health outcomes. And so, as you're going through this, or in your experience, if you could send us any open access training for community healthcare workers, that would be really appreciated.
Yeah, there's a bunch of resources around. Texas is one of a handful of states that has a certification program that's endorsed and led by the state. I think Minnesota, I believe Vermont is close to having one as well. So there's not a standard curriculum that they require. They just have the competencies, and then the partners that I work with have developed over 20 years their curricula. And so there are certain pieces that are definitely open access and that I could share. There's others that I would have to seek permission for. But interestingly enough, there was a WHO call, I think about a month and a half ago, to bring together a technical advisory group on developing training curricula for CHWs. Threw my name in the hat, and the bring. We'll see if it comes out or not. So.
Fantastic. Well, as we'd love to be able to access that and share it widely, and particularly if it's translated into a couple of languages, but just even having it in English would be immensely helpful.
Right. Okay. Yeah, I'll see. I'll see what I can get.
In your
that's
travels,
kind of shared.
in your
Yeah.
travels, you've got a lot of stuff on your plate. Just in your travels, Jason. Don't worry.
No worries. But yeah, I'm looking forward to being in DC next week. So it's been a while since I've been back to the city, so that'll be fun.
Good. Are you able to meet the Hill Day on the 11th, or?
I get in that day, so I'm not going to be able to make it, but
Okay.
I'll be at the conference starting on Thursday night. So.
Okay, fantastic. Good. Great. Well, we look forward to seeing you.
Yeah, that'll be fun. All right, give them 5 more minutes and then we come back.
Okay. I'm going to pop off and try to get back on again. I've got to send all of the poster stuff away, and I've got a pretty long list. So I'm going to jump off and get back on again.
No worries, Keith.
Right?
Good to see you.
But I want to just again thank you very much, Jason. We really,
of course,
immensely grateful. You've done a great job growing and expanding this. And later on we can talk about an election amongst the new members for somebody to co-chair with Richard. And, run that. That would be good.
Yeah, sounds good.
Okay, thank you, Jason.
Right, see you soon.
Bye.
Hey, Luke, just letting you know that all of our participants are in breakout rooms right now. They'll be coming back here in about 2 minutes. So I'm happy to send you to a breakout room if you'd like to go, or if you just want to hang out here and wait till folks come back. It's up to you. You're muted. I can't.
I can just hang out. I'm actually not super familiar with what the session is. I just got a flyer and I was told to sign up. So like totally disoriented. I'm in Salt Lake City. I see out your window. It's not white and like covered in 6 feet of snow. So I'll take a guess. East Coast.
No, I'm in Texas, where it's
Texas,
cold,
nice.
cold and wet right now. So
okay.
Yeah. But yeah, no, we're just doing some small group discussions on kind of topics of the day around global health operations. So they'll be coming back, and then we'll have some room report out. So hopefully that'll help give some context to it. So
sure, great.
Yeah, but thanks for joining us.
Sure.
Hi, Nashika. Thanks for joining our satellite session. Just letting you know that our participants are all in breakout rooms right now, and they'll be coming back here in approximately 1 minute. So feel free to join the discussion once they're all back.
Okay, thank you.
Of course. Right, love it. Hopefully nobody gets lost in the matrix on their way back from the different breakout rooms. Welcome back, everyone. I think it looks like we are all back. Hopefully, as I just said, nobody got lost in the matrix. So hoping it must have been great discussions because nobody came back early. So excited to hear what happened. Abara, if you're talking, I can't hear you. So what I'd like to do is facilitate a quick report out. We've got another 50-ish minutes together here today. So what I'm hoping is we can spend about 30-ish minutes talking about the breakout rooms, inviting folks who weren't able to attend one room to hear what happened in those rooms and maybe continue that conversation. And so here's what I would ask is for our note takers who are in a specific room, as we debrief and open the conversation up, if there's new concepts, ideas, themes that emerge, if you could just document those in your notes for that specific topic or room, that way we can kind of keep it all together. So does that sound like a plan? All right. Well, I'm going to go ahead and get us started, and we'll start with breakout room number 1, which was on contracts and financing. So Anna, not to put you on the spot, but to put you on the spot, why don't you guys start us off?
Okay, good. Thank you so much, Jason. It turns out that 45 minutes is not that long to talk about financing and contracting. But the main thing that we discussed, perhaps not surprising, but just again, just emphasizing the issues. So of course, as we discussed previously, a lot of institutions, especially LMICs, are underfunded for activities in global health. This relates to not only to research, but also to education, capacity building, training, and so on. So a lot of global health activities. Some of the things that we discuss for what the CUGH Operations Committee can actually do is provide a platform, a communication platform where we can establish and facilitate the partnerships, provide templates to establish formal maybe memorandum of understanding and contracts, because a lot of institutions don't have access to these templates, have a database of funding resources, a toolkit also how to pay for the services, especially when you are in LMICs, since a lot of the high income countries relate on advancement of the payments and reimbursement. But that's not a venue for LMIC to do so. Also, even if they have the funding to finance activities, they might not be able to use, for example, the wiring or credit cards issued in their country. So also we discussed something that we mentioned before, but CUGH conference and membership fees might be slightly prohibitive and still high for LMIC institutions. So that's again some feedback that we had. So thank you. I could discuss it for another hour, but I will stop here.
Yeah, thank you, Anna. It sounds like, again, I know 45 minutes, it feels like a lot, and then all of a sudden you realize we just did our introductions and now, now we're talking. So we'll keep thinking about how we tweak these sessions. Any questions for Anna and the group that was in contracts and financing? Any issues that you would like to raise for kind of general discussion amongst the group? Yeah, Richard. Can't hear you.
Yes, correct. Yes, I was raising my actual hand, and then I wasn't on. Anna, thank you so much for sharing those experiences. I wonder, in your group, the group that you are with, and the views you had, how distributed were they in terms of participants in your group? Were they from which regions of the world? And sort of when you're representing what you heard, where are the voices coming from?
So we had participants from the US, Bangladesh, and then one who didn't really say where they're from and joined a little bit later. But we had some representation from LMICs and then high income.
Okay, thank you. Thank you.
I was just going to share this issue of upfront financing for programs is one that's huge, right? And when I was launching one of my initial projects in Haiti and the Dominican Republic, I was able, and I mean, I think this is an institution by institution approach, but I just wanted to share, I was able to convince my Office of Contracts that this was just not feasible. Our partners cannot put up the money required to start the program and then seek reimbursement. And they understood that, and they were willing to help us identify ways of doing upfront payments, and then have them submit receipts on the back end. And so I just wanted to share, it is possible to break down the institutional structures that sometimes limit us to the pre-financing of programs. It does require some innovation and forward thinking, I think, within our contracts offices. And so I just encourage folks to have those conversations with people within their own departments and their institutions to educate our contracts offices about those limitations. And if folks would like, I'm happy to share the structures that we established to be able to do it. Granted, I will admit we were working with philanthropic dollars, which gave us a little bit more flexibility than, say, if it was federal funding or otherwise, but it's possible is what I wanted to say.
Yeah, I would like to build upon what Jason said. I was able to break some some barriers, and even for federal funding, we were able to advance. I came up with this template that is now widely used by UAB faculty members. So yes, it's possible, but it's not easy, and it's good for us to share the resources of how can our administration be convinced to do so.
If I may add, Jason, my experience here at Northeastern 2 and my collaborators back in Kenya is that often, that has worked for me as well, exactly what you have just said, Jason, sharing. But another thing that has worked here is, I have an Amex card that is issued on, as contract, a project related funding. So I have money in the Amex card, and I'm abroad in Kenya, and I can charge cost for whether it's field work or purchases, computers, electronic tools, anything that we need, and I would charge that card and then report back on this end. So that has also worked in my case. Yeah.
We had a question actually from our LMIC partner and in that room, again, building on this discussion, who asked, okay, so this is for, so we developed some tools of how to do that between high income country and LMIC. What about the payments between two LMICs when nobody has money to fund them?
I would love to throw this to the wisdom of the group. Has anybody come up or come across an innovative solution to address this challenge?
Well, can I make a comment? Well, that's where innovation comes in. You don't have money, you create it. This is where I believe community engagement is important. Public business partnerships. You may not have the money from the institution. The government may not give the money, and if they do give the money, if they're not corrupt, you'll get it. But if they're corrupt, you may never get it. And this is where I believe we should engage the community. There might be philanthropies within the community or friends. They may not have large amounts of money, but if you have good support from friends in the community, you can fund some of your projects. I'm not saying that is the entire thing, but that's something that we as practitioners should consider, engaging the community, telling them what our needs are, and creating some partnerships on how we can move forward together for the common good.
Yeah, thank you, Avar. And Shri, before you jump in, I just want to highlight Willa's comment in the chat. Public-private partnerships are important, and you're encouraging folks to attend National Academies meetings. Willa, if you're able to unmute, would you mind just expanding a little bit upon what you mean by that, National Academies, and what the opportunities might be?
Hello?
Yeah, we can hear you.
Okay, thank you. Hello, everyone. Really good meeting. I was thinking about this while I was listening to this. Sorry about any noise in the background. National Academies, you can just type that into Google and get the website for it, but they have lots of meetings that we need more scientists to participate in the meetings, scientists, community. And there are grant opportunities at grants.gov, but you need a sponsoring agency for that. So I'm a council person for people with disabilities in Rhode Island, and I've been a council person for over 10 years, so I kind of know a lot about organizing and systems, and I really love to work on how these things are connected. So we are in a very, 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 very important time in history, but right now this time is important because we can really move forward with a lot of our ideas, and a lot of the stress that scientists have is funding, worrying about how to get funding. And when you're in the process of trying to get funding, you have to do a lot of communication and talking to a lot of other people. So step one after COVID really is to have a mechanism that's going to allow us to communicate more after these meetings, and to have a mechanism that will store the work that we've done so we don't have to keep doing this over and over again. And what we are eventually going to start doing is moving it. So what I am asking everyone in the group today, and thank you for listening to me, is for a way to contact you guys after about this idea so I can elaborate on that more and get more scientists and people in the community involved for public and private collaborations. And it's not as difficult as people think, so just start putting your information together and getting it ready to move, because this is the time, and people have to know that, because I think people think that things are going to be reoccurrent, but you have to know to be in the now and move through it. And we can really get some of these things done if we're not overwhelmed by how many categories of things that need to be addressed. So thank you, guys.
Willa, thank you so much for those comments. Really, really appreciate your chiming in. And yes, we will share contact information for our subcommittee or our committee in particular, so that the goal here is that this conversation doesn't stop today. This is a continuation. And so we want to also understand how best can we continue to engage with this learning community. So really appreciate that.
Yes. And I will tell several people about this from Rhode Island. I don't know if you guys know anything about Rhode Island, but I talked to both of the senators, both of the reps. I go to a lot of meetings here, but I go to a lot of meetings in the US, and I like international meetings also. So I am giving you hope, because I know that we can build capacity. And if we just take these tiny steps in doing it, then we'll find that we are so much greater than the sum of our parts. And we're all just like, we have to talk about this. This stuff is going on now. We've got to move this. We will move it, and we can.
Love it.
Good.
Love it. Thank you, Willa.
Excellent.
Shri, do you want to jump in? And then I want to recognize Eastman's comment in the chat, but Shri, go first.
Yeah. So just to build on what Ibarra said and Willa said, a couple of things. For the private-public partnerships, there are several platforms that do this, independent of the federal and state governments. Especially if you look towards California and the Northeast, there are platforms that are with the organization in the middle. They have people with needs to the left of the platform, and people willing to offer and help with those needs. So those platforms basically match up, and I'll be happy to share some details of that after the conference with the committee and anybody who's interested. As far as Willa's points are concerned, I do attend NASEM workshops, which is the National Academy of Sciences, Engineering, and Medicine. And what NASEM does is, from time to time, they have this open listening workshops where anybody from the public can chime in and offer a comment. And when I first started doing that, I was surprised that often I would hear back from the program or the scientific officer from NASEM. For example, there was one recently about public protective equipment that I attended, and I gave my 2 cents, and then somebody followed up with me and sent me an email back and asked me what it is that I wanted to do with them. So that's a great forum. They're very open to hearing back from the community, and there are some sessions that are just for public listening and public feedback. If you sign up to the NASEM website, you will get a link whenever those sessions show up, and you can always respond to it. There's also an option sometimes when they put out a document where you have a 4-week period where you can go in and comment on that particular document before it's released. So that's a great way to offer your input and perspective. The other place to sign up is the PCAST, which is the Presidential Council of Advisors for Science and Technology. And they also from time to time have what they call as federal listening sessions. Depending on the session, if it's one of your interests, you can always join in, and you get to talk to people in the White House and the Presidential Council of Advisors on subjects and comment on them. And so it's a great opportunity. So the third thing I wanted to point out, which I think I may have forgotten, is that NASEM also releases briefs of these workshops as a PDF document. So as a guest, you can go in there and download those documents and go through those. There was one recently on preparedness in terms of public health pandemics, which was an excellent workshop. There was also one about AI and role of AI in global health as well, which is something Annalisa, I'm sure, would be very interested in. So there's a lot of options and a lot of information out there. So I just wanted to share that.
Yeah, thank you, Shri. And I'm just going to give voice to Eastman's comments here. I wish we could hear more about it, but I want us to move on. What Eastman was sharing from his experience in Ghana is the rational use of resources so that if they have savings within one project, they carry those funds forward into new projects to be able to kind of provide seed funding, and then success breeds success, and then other people want to be a part of it. So I really like that that approach, Eastman. Thank you for sharing it. Yeah, Shri.
Hey, sorry about that. There are two other points I wanted to make. I have always mooted, for example, to the Advocacy and Communications Committee that we need to have a dedicated platform, whether it's a Slack channel or anything else, for everybody to be on the same page and have what we would call as a synchronous communication, not necessarily by email or not necessarily at conferences. Because one of the problems that happens is when you're at the conference, everybody's energized. But if you don't capture the energy afterwards, like Willa just mentioned, it all goes to waste till we come back for CUGH 2024. So I've advocated that either we have a Reddit channel or a Slack channel or whatever channel we want that works for everybody, so that it's a continuous communication where anybody can wake up each morning, afternoon, or evening and post whatever it is. And anybody within that 34,000 membership that we have can respond to that particular challenge. Unless we have that, we're always going to be operating in silos with no informal communication happening throughout the year. The other point I wanted to make about funding, I'm part of the membership committee, and one of the plans that we just submitted to the board of directors was a way for high-income countries to subsidize membership for low and middle income countries. We're looking at a plan, and this is still not out there in the public domain, but we're looking at a plan where we subsidize membership for about 3 years and help LMIC and MIC members to join the CUH bandwagon and the platform so that their voices, their thoughts, and their ideas become part of our work. So I just wanted to share that.
Thank you, Shri. So much good information. I love these conversations. All right, I'm going to move us on to breakout room number 2, which is LMIC to LMIC travel challenges. So Abara, take us away.
Thank you very much, everyone. We had a very robust time talking about travel challenges. And I tell you, we had comments from South America, from Africa, from Southeast Asia, from, of course, the USA and Canada. And it ranged from visa problems, disparities in the questions we are interviewed as we are being granted visas, delays at the embassies, and name it. And we also had some solutions, but I'll talk to that. Then we talked about funding, how LMIC learners and faculty are underfunded, either from the government or from the institution, or both. And these are things that limit the ability for them to travel. Then we talked about issues in terms of time, how long it takes to go through a process to get an interview and then get a visa, and the limitations in the visa. We also talked about LMIC travels. There are inherent infrastructure problems where global health professionals may not be able to travel from one center to a rural community because of bad roads, flooding, and so on. And also where we considered conflict as a major factor in healthcare. In communities where there are conflicts, global health practitioners are not able to travel freely without danger to their own health and also danger to the people they're going to look after. Now, like I said, there were lots of talk, and we also have solutions. And some of the solutions are, one, we think that the CUGH should create an advocacy group, if they already have it, to enhance it in the sense that they will create collaborations with government, public, private partnerships to facilitate the travels of our global health learners and faculty and build resources. We also think that there has to be a way of creating resources for global health professionals, particularly those traveling from LMIC countries. But one important factor, which one of us was very emphatic, is how young people are not treated fairly. And that's where we call there's a disparity in how various countries or various people look at others. And the young people who talked about it were very, very, very strict in terms of stating that they felt very uncomfortable in terms of disparities. Now, we know that this is something that we in this organization consider equity, inclusivity, and collaboration. So we think that the organization, CUGH, and particularly the Operations Committee, should continue to promote this and advocate for the welfare and ease of travel for our members. Now, I will stop here because I think we had information from 5 global areas in the world, and they were saying the same thing. I haven't given detail, but we'll be glad to share the details outside here.
Thank you, Abara. Sounds like a great conversation, and I can just share from my own experience. I have a good friend and a collaborator in Burkina Faso in West Africa who's been trying to come to the United States. And I know we were talking LMIC to LMIC, but his experience, 2 years in a row, he's never been able to get his visa interviewed to be able to come and travel here. So I know that's an internal issue, but it's a challenge because we want him to come and share his knowledge and expertise with our learners and with our administrators, and it's been an issue. So I know this issue affects a lot of folks. Any questions, comments for Abara in the LMIC to LMIC travel work group or breakout session, not a work group? Other observations or thoughts? I do like that idea of creating the advocacy tools within CUGH. I think there's a lot of power and resources that we can bring together as a collaboration to try to affect that change of RSO.
Yeah, absolutely great points again. And I wonder again if the templates, even the invitation letters to be used at the embassies, something simple like that can make a huge difference, you know, the wording, etc.
Yeah, Shri, and then we'll move on.
Yeah, just 10 seconds. For those who are interested in advocacy of any sorts, I urge them to look at the Union of Concerned Scientists website, which runs training programs for advocacy free of cost. It's usually a 1 or 2 day webinar, at the end of which you'll get a toolkit that you can take and disseminate in the community. And basically you'll get some principles for if you're kickstarting your advocacy career. They have all the steps that you need. They also have a toolkit that allows you, for example, to interact with your local Congress offices, so on and so forth. So it's a great resource. Just want to point at that.
I'm muted. Thank you for that, Shri. Thank you, Abara, for that report out. Looking forward to seeing the final notes on that. Sorry, let's move to Shri, workforce development and shortages breakout room.
Thanks, Jason. We were just 5 people in the room, me, the note taker, and 3. When I first started out, I was skeptical about what we would be able to achieve, but I'm glad there was just 5 people because we had a very informative discussion. Of my participants, we had 2 from Ghana, one of whom, actually 2 from Cairo rather, one of whom is currently at UTMB and also has US-based experience. The 3rd participant was from Ghana. 2 of them were physicians, both from Cairo. and the individual from Ghana is a public health educator, and all of them were very open and vocal about their views on this subject. I let them talk freely. What emerged was a couple of things. Workforce shortages are real, and these shortages were felt worst during the pandemic. They're slowly getting out of these shortages and moving back to a more better situation, so to speak. But overall, the shortages still continue to exist. We talked about shortages with physicians, we talked about shortages with nurses, and we talked also about shortages with global health professionals or public health professionals. So these are real. And even though the pandemic is quote unquote on its last leg, the shortages still continue to be there and have not been fully addressed. As far as reasons for shortages were concerned, they basically, I think, three themes emerged. One is that less people were graduating. Two, those who graduated, especially during the pandemic period and the immediate post-pandemic period, if we can call it that now, they didn't have any formal real-world training because most of their training was done online. One of my participants actually said 70% of the doctors that she knew who graduated were all quote unquote online doctors because they had not actually had any formal training in school. So those people are now undergoing a retraining process to actually know what it is to be in a hospital and to actually interact with live patients, which was a little funny, but that's how it is. As far as all of these people not having real life training, the problems were there was a shortage of personal protective equipment, there were shortages of drugs, shortages of vaccines, all the usual things, and of course shortages of funds as well, which made it impossible for these people to actually go physically to hospitals and carry out their work. The individual from Ghana also mentioned that we needed some attitudinal changes towards both workforce development and shortages, because the focus seems to be on non-communicable diseases. But his opinion was that infectious diseases are equally important. And so we need to spend a significant portion of our time, as this pandemic has illustrated, also on infectious diseases, because we all know this is not our first and last pandemic. In terms of what should we do to going forward to address some of these workforce shortages, was financial incentives. And I mentioned to them that even though financial incentives were offered to nurses and physicians during the pandemic, nobody expected the pandemic to last this long. And so people were burnt out. And so despite the financial incentives, a lot of people were transitioning out of the workforce. In the case of Ghana, this individual mentioned that several people from Ghana were also migrating overseas in spite of the financial incentives. So coming to the last portion of the thing, and like all the other people who are in the breakout room, I can talk about this for a couple of hours, but I'll make it short. What they said, I asked them, what would you like for CUGH in general and this committee in particular to do to help with those issues, workforce shortages and workforce development? So the first issue that came up was funding. They wanted that we have coursework, and we also have some funding mechanisms that will allow the voices from the Global South to be incorporated in all of our work. For example, a seat at this committee, a potential webinar, travel to our annual conference, so on and so forth, so that their ideas, their thoughts, their views become a part of our conversation. The second thing they mentioned particularly was that it has to be multidisciplinary. You have to have people of all hues, not just public health professionals or global health professionals, but different people with different backgrounds, because pandemic preparedness or global health preparedness or tackling challenges in global health is a multidisciplinary process that no one group or one individual can handle. It has to be a group effort, as Willa also mentioned. So everybody needs to have a voice. So I told them one option is to sign up for the CUGH newsletter and look for committee opportunities and then apply and join those committees. In some of the other committees, like the advocacy committee, for example, Keith always asks members if they know of anybody who would be a valuable addition to the committee. And this is outside of the regular committee, announcement that is put out once or twice a year whenever the vacancy arises. Keith, in fact, says if you come across someone or with a voice that could be important to the work of the advocacy and communications committee, just reach out to them and have them contact him or any of us and bring that person on board into the committee. That's something that we could potentially also do at the Global Health Operations Committee. We run into so many people, and sometimes if their voice is important, just bring them on board. The last and most important point is in addressing these workforce development or workforce shortages, it should not be a top-down approach where somebody sitting in Washington or elsewhere tells the rest of the world what to do. It has to be a context level solutions, meaning global problem, regional solutions, which is that you first take into account the problem that you are solving and the regional context before you develop a solution, which I thought was very, very important. And I gave them the context of the WHO said that you had to wash your hands every time you touch something during the pandemic, which was great. But then several parts of the world don't have water for daily activities. So it doesn't make sense when you send out a recommendation like that, that is obviously not applicable to the local issues. So global problems, regional solutions was another important takeaway. So like I said, I can talk for a few more minutes, but I'll leave it there.
Yeah. Thank you, Shri. I know the workforce development and shortages issue is an ongoing issue in global health collaborations and partnerships. And it's exciting to bring this to our committee because I do think there's a role that we can play as operations to think about whether it's investigations, creating advocacy tools, like you said, or forums for conversation to really assess the push-pull factors that are creating the shortages in our low and middle income countries. So I really appreciate the work that you guys did to have that conversation today. I'm sure there's comments that others want to make, and I would say please put them in the chat because I want to make sure that we give enough time for our final breakout room to share. So any additional conversations on workforce shortages, have it on the chat. And Alicia, will you walk us through the fourth and final breakout session on technologies and global health operations?
Sure, and I will try to keep it brief. We also had some lively participation and some really excellent insights that were shared. So thanks again to everyone that joined the technologies breakout room. Essentially, this is a huge area and really would need many more hours to really dive into some of these specifics. But some of the broad themes that we discussed are some of the overall benefits that can happen from digital health access. So on the large scale, you have data collection and analysis, which can be useful for everything from analyzing public health trends and informing public health teams. It also touches on grants and funding justification when you have that large scale data. And you see that play out on the international stage as well. The research that can come from large scale data acquisition has significant potential in many different directions. And then also using that data to justify and influence policy and government officials, which can sometimes pose a barrier to regions trying to access different technological innovation. In addition to the data side, there is the concept of educational benefit that can come from different digital technologies, whether that's education amongst medical personnel. We had one great example of telesurgical consultation in Uganda, but also the concept of public health education and being able to use media and technology to reach populations to better disseminate information and health information as well. Medical access is something that we see as a benefit from digital health. So telemedicine was a topic that came up and has been widely discussed in the setting of the pandemic, obviously. There's also tangential pieces like improved diagnostics and therapeutics. We heard about a drone delivery service in Ghana. That sounds fascinating. I had not seen drones used in that context before. And then also the idea of using wearables and different point of care tests in Brazil to mitigate some of the medical setbacks that we saw from the COVID-19 pandemic, including maternal morbidity and mortality outcomes in that region. The other piece, though, when you think about the opportunities that can come with digital health, is the idea of challenges. So I know Shri had touched on the digital divide, and that is another broad concept, but can, I think, be broken down into a couple main themes, including just the technology access itself. So connectivity, we talked about reliable internet, being able to access things offline, but then if you need to then upload that data online, making sure you have avenues for that. And then the other piece, in addition to the software and hardware elements of digital health, the literacy piece. So whether individuals are able to have the digital literacy to use the technologies, but then also the health literacy piece. And so getting buy-in from different groups, including partners on the ground. So we talked about some national data collection efforts in different parts of the world, and did see a common theme in struggles to get buy-in from certain partners, especially in the private sector, for those types of efforts, but then also buy-in from patients. And I think we all did see this with COVID as well. The idea of motivation for lifestyle modification, things like washing your hands, but also different strategies, non-medication strategies to address things like non-communicable diseases. And then a big piece of digital health, which I think can often be overlooked, is the idea of misinformation and how we as the health community can be thinking consciously and effectively finding solutions to mitigate the impacts of misinformation that we also see. So all that to say, I think there's a consensus that this is a developing area. And so finding opportunities to share best practices, as well as educational opportunities for different regions to be using these technologies the most effectively and trying to address that digital divide is going to be extremely important moving forward. And we did have Richard on our group as well. So I want to give him the space to share any additional insights.
Well, thank you, Annalicia, very well, I think, presented. We had a broad discussion, and thank you for framing that. I think, I'm not sure whether we had the largest participation in the group. So there was a lot of topics to discuss there, Jason. I can see that I think we'll really get this report, Annalicia, compiled all of these notes from the different groups, and the committee will discuss them, share them more widely. I think Jason will make those concluding remarks. With that, I just don't want us to go over time, so I'm not going to comment any further than what Annalicia has just stated. So, thanks, Annalicia.
No problem.
Yeah,
and I do see. Oh, go ahead, Jason.
No, go ahead. Go ahead.
I was just going to say, I see Shri has his hand raised.
Yeah.
Yeah, Shri, if we can make it quick.
Yeah, no, I just want to thank Annalicia for reminding me about the telemedicine thing, because in our workforce shortages group, telemedicine was one of the topics discussed. We had a surgeon in there who talked about telemedicine and remote surgery, both in terms of patient care and also as an educational tool. There was a recent survey out on all of these technologies, basically genomics, AI, robotics, and digital technologies. And the number one tool that is supposed to disrupt healthcare, whether that's global health, public health, or healthcare in general, and it's going to span till 2045, is telemedicine. AI is slightly lower down on the list because the ethics and governance part of AI and the bias part of AI is still not being addressed. So without addressing all of those, and also the problems with machine modeling and all of those things, it's slightly lower down on the anvil. But as COVID has shown, telemedicine is really critical, and virtual health we're going to move from physical healthcare to virtual healthcare, and the future hospital is going to be home. So remote patient monitoring and all of those technologies, including wearables that put data in the cloud, those are the future. So I just wanted to add to that.
And I'm just going to make my plug for continued involvement of humans, regardless of how much technology we bring to play. And this is the important role of community health workers and other allied health professionals, because I do think there's a role to continue to play to have that human to human interaction, and you marry it with technology. So I say that to say, I'm really appreciative of this entire conversation today. Thank you to all of my fellow committee members for leading these discussions, for helping us form what I think has turned into a really robust conversation and fruitful dialogue today, really helping give our committee directionality for the next year, possibly more. And this was our goal, right? We want to be responsive to the needs of not just our CUGH member institutions, but those of us that are working in these spaces, whether we're focused domestically in our own countries or internationally. Global health is local health. It all happens where we live. And as we've now learned through the pandemic, diseases do not respect boundaries and borders. And so for us to really achieve health equity globally, it requires us to be thinking locally as well as around the world. And so I appreciate all of this. I'm going to share a couple of quick slides just to wrap us up here, because I feel like there was a lot of conversation that needs to continue. So first of all, if you have additional questions, comments, if you have interest in joining this committee in the future or participating in any of our future activities, because I think I've heard there may be some webinars in our future, there may be some future learning collaboratives, please feel free to contact myself or Richard Romai, both of whom we've been on this call today. Our email addresses are here. We would love to hear from you. I'm going to make one quick plug, and then I'm going to open this up for any final reflections from my co-committee members here. Please don't miss out on our Global Health Operations breakout panel at the conference, which will be starting next week. So again, this is the precursor to the larger CUGH annual conference. That conference begins on Friday. Our breakout panel on mapping the effects of climate change on health systems, preparedness, and vulnerabilities will be on Sunday, April 16th from 9 to 10:30 a.m. This will be in the session live, moderated by Dr. Romai, our co-chair, as well as a few other members of our committee. Should prove to be a very interesting and fruitful conversation as well. Richard, anything you want to say on that point before we close this up?
No, thank you, Jason. Just to obviously invite everyone, and obviously looking forward to meeting committee members as well as participants in this live event that we will have in Washington, D.C. So I'm excited about being there and our speakers who will be joining the panel here. I think we prepared a very good panel and look forward to seeing people there who are able to make that conference in person.
Great. And as a reminder to our committee members, we will have an in-person meeting bright and early on Sunday at 7 a.m. I'll send you details of those. Hopefully you'll be able to join. We'll have some coffee and some pastries, I believe, or at least some little continental breakfast. But again, to all of you in our learning community around the world, thank you so much for sharing the past 3 hours with us. This has been, for me, one of the highlights of my leadership on this committee. It's coming to these meetings, it's hearing from you, the folks in the field doing this work and helping give us direction to the work that we can do so we can provide better products, better services, so that we can all achieve our collective goals in global health. So on behalf of our entire committee, on behalf of the CUGH institution, thank you so much. Again, wishing everyone the happiest of Easters, the happiest of Passovers, the happiest of Ramadans. If I've missed one, I apologize, but I'm pretty sure all of those are happening right now. And thank you again for your participation and your eager conversations.
Thank you.